Hi everyone, and welcome to our module on renal tubular acidosis. So I've listed on this slide all the causes of non-anion gap metabolic acidoses, and I discuss all these causes in the module on metabolic acidoses. But here we're going to focus on this last group of disorders called the renal tubular acidoses. So RTAs are rare disorders of nephron ion channels, and they all cause a non-anion gap metabolic acidosis. And there are sometimes symptoms associated with these disorders, but many times patients are asymptomatic, and the way they're discovered is that routine blood work is drawn and it shows a low bicarbonate level from the acidosis, and it often also shows an abnormal potassium level. So we'll start by talking about the type 1 or so-called distal RTAs, and these are disorders where the distal nephron cells cannot acidify the urine. So the nephron can't excrete acid, and as a result, acid levels build in the blood and the patient develops acidemia. Also in type 1 RTAs, the distal nephron cannot resorb potassium, so patients develop hypokalemia. So this is easier to understand with a drawing. So we're going to draw the distal tubule or the collecting duct here, and normally hydrogen atoms are being secreted into the urine here, but in patients with a type 1 RTA that doesn't happen because of an ion channel defect. As a result, more negative charge builds out here in the urine, and that will hold potassium in the urine so that it doesn't get resorbed. The result is that you're going to lose in the urine potassium, and you are going to maintain a high level of hydrogen ions in the plasma, giving you an acidosis. So one thing that's very useful to know about type 1 RTAs is that they result in a very low bicarbonate level, often under 10. Recall that a normal bicarb level is 24, so if you are suspecting an RTA in a patient and the bicarb level is 6 or 7 or 8, very low and under 10, it's most likely a type 1 RTA, and that's a very helpful piece of information to know. The urine pH in type 1 or distal RTAs is high because, like I just showed you in that drawing, you can't acidify the urine. You can't get hydrogen atoms into that urine, so the urine becomes alkaline. And in fact, you can establish the diagnosis of a type 1 RTA if the urine pH is over 5.5, which is high, despite a metabolic acidosis. In the setting of a metabolic acidosis, the urine pH should get very low as the body tries to excrete hydrogen atoms. If the urine pH is high, which is over 5.5, it tells you there's a defect in excreting hydrogen ions, and that's what happens in a distal RTA. So as I said before, a lot of patients with RTAs are asymptomatic and the disorder is picked up on routine blood work, but there are some key symptoms you should know about, especially for your boards. So patients with type 1 RTAs often get chronic kidney stones and rickets. So the alkaline urine precipitates stones, and these can sometimes be bilateral. If you ever see a patient with bilateral stones in a board question, you should think of a distal RTA. The acidosis increases the calcium resorption from bones, and this leads to calcium in the urine, which leads to kidney stones. The acidosis also suppresses calcium resorption, so this even more leads to calcium in urine. And then all this calcium resorption from bones can lead to rickets, which is essentially a bone demineralization problem. And then in children who have a type 1 RTA, and it's sometimes inherited, will have growth failure, and this is a result of the bone problems related to RTA. There are many etiologies of type 1 RTAs, and there are genetic or inherited forms, but something that's extremely high yield to know for your boards is that these are associated with autoimmune diseases, especially Sjogren's and rheumatoid arthritis. So in a board question, a patient with a type 1 RTA is almost certainly going to have one of these two disorders. These are also associated with use of certain medications like amphotericin B. Measurement of the urine anion gap is very helpful for making the diagnosis of a type 1 RTA. So when you have an acidosis, lots of ammonia gets excreted. Ammonia is a buffer that helps to remove hydrogen ions. It's difficult to measure ammonia directly, so instead we use the urinary anion gap as a surrogate, and the formula for urine anion gap is different than the formula for the plasma anion gap, so don't get confused. To calculate the urine anion gap, we add the sodium and potassium concentrations in urine and we subtract the chloride. And the reason this changes in the setting of acidosis is because those high levels of pneumonia take chloride with them. So pneumonia leaves the body with chloride. This makes the urine anion gap negative when there's lots of H plus being excreted. So you should have a negative anion gap in the setting of an acidosis. So for example, in a GI metabolic acidosis like from diarrhea, the urine anion gap becomes negative because you're excreting lots of ammonia with chloride. The urine chloride concentration goes up, and that means that the urine anion gap is going to become negative. In contrast, patients with a distal RTA have a positive urine anion gap, and this is very abnormal. The urine anion gap should not be positive in the setting of acidosis. But this happens in a type 1 RTA because the kidneys can't excrete H+. Therefore, the ammonia and chloride levels don't increase. Therefore, the urine anion gap level, which is sodium plus potassium minus chloride, does not become negative as it should. Another way you can make the diagnosis of a type 1 RTA is to do something called an ammonia challenge. So you administer ammonia chloride, this is called an acid load, and this should lower the urine pH, but in RTA the urine pH remains greater than 5.3. So I've summarized two very high yield points down here on the bottom for you to remember. A negative urine anion gap occurs in acidosis from a GI cause. A positive urine anion gap occurs in acidosis from an RTA. And this is how you can make the diagnosis of a type 1 RTA and exclude that diarrhea is the cause of a non-anion gap metabolic acidosis. So the classic case of a type 1 RTA that you should know for your boards is a patient with Sjogren's disease or maybe rheumatoid arthritis who has recurrent and bilateral kidney stones. The blood work shows a very low bicarb. Remember that in type 1 RTAs the bicarb gets under 10. There's hypokalemia. The urine pH is high, which is greater than 5.5. The urine anion gap is positive, and it should never be positive in acidosis. And if you give ammonia chloride for an acid load, the urine pH will remain high. And the way you treat this type of RTA is to administer bicarbonate to try and blunt the effects of the acidosis. The next RTA we'll discuss is the type 2 or proximal RTA, and this is a defect in proximal tubule bicarbonate resorption. So a very important thing to know about this type of RTA in contrast to type 1 is that the urine pH will be low in a type 2. Recall that in type 1 it was high. The reason it's low is because the distal tubule can still excrete H+ in a type 2 RTA, so it's able to acidify the urine. So if you develop a type 2 RTA, initially the urine pH may be high because you're excreting a lot of bicarb, but then quickly the distal tubule is going to excrete H+ as the acidosis becomes established, and this will give you an acidic urine. You also get hypokalemia in a type 2 RTA. You lose bicarb resorption, and this results in a diuresis and a volume contraction, and that leads to high aldosterone levels, which promotes potassium excretion and hypokalemia. The degree of suppression of bicarb is milder than type 1, so the bicarb in a type 2 is usually in the range of 10 to 20. Recall that I said in type 1 it's very low, usually less than 10. And again, this is because those distal collecting tubule cells still function normally, and they're able to secrete acid to compensate for the acidosis. There's no kidney stones with this syndrome, so that also helps separate it from type 1. And then you should be aware that a proximal type 2 RTA often occurs as part of Fanconi syndrome. So Fanconi syndrome is when the entire proximal tubule doesn't work. So you can't resorb phosphate, you can't resorb glucose, amino acids, urate, protein, all these things get lost in the urine. And the main symptom that happens in children with Fanconi syndrome is they get bone wasting from all the phosphate loss. But as part of this generalized loss of function of the proximal tubule, you can see a type 2 RTA. So there really is no classic case for type 2 RTAs like there is for type 1, but a sample of what you might see is a patient who has no symptoms and gets routine blood work, or maybe a patient with mild weakness from low potassium gets blood work done, and you find a mildly reduced bicarb level in the range of 10 to 20. Recall that normal is 24. You see hypokalemia, and then when you check the urine pH, you find that it's low. And this type of RTA also can be treated with sodium bicarbonate. Our final renal tubular acidosis is a type 4 RTA. There is no type 3 RTA. And in a type 4 renal tubular acidosis, the problem is that the distal tubule cannot respond appropriately to aldosterone. This can be due to either an aldosterone deficiency state or resistance to aldosterone, and we'll talk more about that in the next slide. When aldosterone cannot perform its job, the result is decreased excretion of potassium and thus retention of potassium ions. Therefore, this is the only renal tubular acidosis that is associated with hyperkalemia. The urine pH in a type 4 RTA usually remains low, and this distinguishes it from a type 1 RTA where the pH is high. And then finally, an important feature of a type 4 RTA for you to understand is that in this disorder, there is impaired ammonium excretion by the kidneys. This is what leads to the acidosis. In the video on acid excretion, I talk in detail about how ammonium is the major mechanism by which the body excretes hydrogen ions. Therefore, when there is impaired ammonium excretion, the result is impaired excretion of hydrogen ions. This leads to a fall in the pH, and that leads to the acidosis seen in type 4 RTAs. What happens in a type 4 RTA is that because of a failure of aldosterone effects, the potassium level in the plasma becomes high. This has an important effect on cells of the proximal tubule. In those cells of the proximal tubule, when the potassium level surrounding the cells is high, the pH inside the cell gets very high. When the pH inside the proximal tubule cells is high, they do not synthesize ammonia normally. And as you may know from the acid excretion module, the synthesis of ammonia is a major way that hydrogen ions are eventually excreted by the kidneys. So because aldosterone cannot do its job, the potassium level rises. That leads to less production of ammonia by the proximal tubule cells, and that leads to less ammonium excretion by the kidneys, and that leads to the acidosis seen in type 4 RTA. So I said before that this can happen either because of decreased aldosterone production or aldosterone resistance. So let's talk about some of the reasons these things might happen. One of the most common reasons for a type 4 RTA is diabetic renal disease. In diabetic kidney disease, there's less production of renin and therefore less production of aldosterone. In addition, patients taking an ACE inhibitor or an ARB have disruption of the renin-angiotensin-aldosterone system, so they have less aldosterone around. NSAIDs can also disrupt aldosterone production, and then finally, adrenal insufficiency for any reason leads to less aldosterone, and that can lead to a type 4 RTA. Aldosterone resistance can occur if a patient is taking a potassium-sparing diuretic. The aldosterone cannot exert its effect in the setting of these drugs. In addition, the antibiotic TMP-SMX is a notorious disruptor of potassium excretion, and it can disrupt the effects of aldosterone on the distal tubule. So the classic case of a type 4 RTA is a diabetic with renal insufficiency who develops unexplained hyperkalemia. This patient likely has a type 4 RTA, and this can potentially be treated with fludrocortisone. It's a mineralocorticoid, and it has effects similar to aldosterone, and it can be used in some cases to resolve the state of aldosterone deficiency. So on this slide, I've just reviewed the three types of RTAs. In type 1, you have a distal problem. You have a high urinary pH. These are the patients who get those kidney stones, and they have a very low bicarbonate level. In type 2, this is the proximal RTA. These patients have a milder acidosis, and they can also have Fanconi syndrome, where the whole proximal tubule is dysfunctional. Type 4 RTAs are a state of aldosterone deficiency or resistance. These are the ones with high potassium levels, and this happens to diabetics and people with renal failure. And then down here at the bottom, I've shown some more key features. So type 1 is a problem with the distal potassium hydrogen ion exchanger. There's hypokalemia in the plasma and the urine pH is high. Type 2 is a proximal problem. There's also hypokalemia in this RTA and the urine pH is low. And then type 4 is the aldosterone channel problem. The plasma potassium is high. This is the only RTA with hyperkalemia, and the urine pH will be low. And that concludes our module on renal tubular acidosis.